Good afternoon, friends. It is my privilege to uh, moderate these sessions. The session we have this afternoon. I am Dr. Philip Finney. I am one of the consultants, endocrinologists at the Believers Church Medical College Hospital at Kerala, and also I'm an alumnus from Christian Medical College, Vellore. It is my privilege to welcome you all to this interesting CME we have this afternoon, which will be focusing on young onset diabetes mellitus. And I know that many of you have registered from all across the country, from people as far as in Assam to the western parts of our country, as well as from the north and south. So it's a very nationally representative audience we have today for this CME. I'm sure you're going to have an academic feast. My co-chair will be Dr. Sudeep, who is my colleague, and he will be chairing the next part of the talk where Dr. Asha will be speaking. And we have 3 talks lined up for today. And we're going to start off with the first talk for today, which is the differential diagnosis of young onset diabetes. And the person who will be leading us in the deliberations will be Professor Nihal Thomas, who is currently the professor and head of the Unit 1 in CMC Vellore. He's my teacher and mentor, a good friend of ours who supported us for many, many years. And I've known him for the last 30 years nearly. Dr. Nihal has had various accomplishments to his credit. He has been the vice principal as well as the deputy medical superintendent of CMC Vellore, as well as the associate director of CMC. He has more than 300 index publications. He has been acknowledged as a PhD guide. He has guided students, as well as he has done his fellowship of the Royal College of Physicians at Edinburgh, London. And he's also been a great mentor to many of us, and many students across the country have benefited from his teaching and training. This afternoon, before I hand over the session to Dr. Nihal, I want to just warmly welcome him to the CME and really say it's a privilege to listen to you. There's a problem, which is a vexing problem, and we have young people who come with diabetes, trying to distinguish which type of diabetes, and it's such a pertinent topic. And we're really happy you're here with us, Dr. Nihal. We really look forward to your talk, and we will take questions at the end of the talk. Thank you. Over to you, Dr. Nihal.
Thank you, Dr. Philip, and good afternoon, everyone. So I'll be covering young onset diabetes and a diagnostic perspective. And of course, it's important to know that there are several important differential diagnoses for young onset diabetes. So the burden of diabetes has increased significantly across the world. And of course, across India, it has increased even more in a deeper proportion. But if you actually look at this distribution, of course, you can see over here the nationwide distribution and certain states in the country which have a greater proportion. This largely talks about type 2 diabetes. Having known this data from a more personal perspective, if you look at the data more carefully, we find that it is not only type 2 diabetes which has increased in its proportions, but also other forms of diabetes which have increased as well. Now, if you look over here, we have up to 30 years, 2.3% of all patients who have diabetes, other than type 2 diabetes, was around 240,000 in 1990. Now, this has gone up significantly and probably is more than 1 million. It's a rough estimate, and it could be a standard deviation, maybe about 10 to 15% in either direction. Whatever said and done, this is a huge number and equivalent to the population of medically moderate-sized countries. So if you look at the WHO classification, and indeed we're very fortunate that the latest classification dates back from 2019, which is very recent. And this happens only about once in a decade or a half that WHO updates its classification. We have very clearly type 1 diabetes and type 2 diabetes. And then we have this category called the hybrid forms, other specific types, and unclassified forms of diabetes, which are open to debate, but certainly do exist. So when we see a patient with young onset diabetes, we need to take, for one, a very detailed history, draw a pedigree chart, do a proper and detailed physical examination, looking at the height, weight, BMI, skin fold, thickness of the skin, features of insulin resistance, etc. And then we need to measure the C-peptide levels, preferably both fasting and in the postprandial phase. Then we measure the GAD antibodies, which is very important to differentiate type 1 diabetes from other forms, which may be positive in about 80% of cases. And then we do imaging of the abdomen when we feel that there may be a cause for diabetes, which may be precipitated by a pancreatic disorder particularly. Now, these are tests which are done perhaps at the level of a secondary care center. And occasionally, of course, you need to refer patients or even the samples of patients for further testing, which are the latter tests which I have mentioned over here on the list. So coming first to the various forms, and I will go by saying that the commonest cause for young onset diabetes below the age of 25 years is still probably type 1 diabetes. But then it is very important to rule out the other causes because the treatments can vary. There are situations where you can use oral anti-diabetic agents other than insulin, and it's important therefore to differentiate these forms. So I'll go backwards rather than forwards, and I'll talk about hybrid forms of diabetes. Here is a 29-year-old male with a history of polyuria and weight loss. He does not have any other symptoms to suggest a gastrointestinal disturbance. His BMI is on the lower side, 20 kg per meter squared, and he's ketosis resistant. He does not have, despite episodes of hyperglycemia on multiple occasions, his ketones are negative. He has good glycemic control achieved at the end of first year with oral anti-diabetic agents and subsequently required insulin thereafter. So because of his leanness and the hyperglycemia and the refractoriness towards oral anti-diabetic agents, he had a GAD antibody tested, and this is elevated. The normal threshold is more than 10, but of course, when we have patients who are frankly GAD antibody positive, in most situations, they are more than 300 JDF units. The imaging of the abdomen was normal, and the C-peptides were low after good glycemic control. So subsequently, basically, we make a diagnosis based on the fact that this is an immune-mediated form of diabetes, young onset, lean, and this is called slowly evolving immune-mediated diabetes of adults, formerly called LADA. These patients need insulin as therapy. We cannot withhold insulin here, and by and large, they may need a basal bolus or a split mix form of treatment rather than pre-mixed insulin. So we go on to the next group of patients, another form of hybrid diabetes. So this is called ketosis-prone type 2 diabetes, initially reported in Afro-Americans in the United States and subsequently in Africa, as well as in Chinese populations, until more recently in the last decade being reported in India. Unprovoked ketoacidosis looks like type 1 when they come in initially, or like say a LADA with high glucose levels and their ketones are positive. But when we do the GAD antibodies in these patients, they are negative. They have a very explosive onset. They can be very sick when they come in, and you need insulin in the initial phase. But usually by the time you reach the 4th month, you can actually start weaning off the insulin. They can be managed with diet and oral anti-diabetic agents. Initially called Flatbush, named after a suburb in New York, in Brooklyn, called Flatbush, and therefore called Flatbush diabetes. The onset resembles type 1 with features of the metabolic syndrome. They tend to be a little overweight or obese, but then they subsequently transform into what looks more like type 2 eventually. And this is work done by my colleague in the department some years ago, which showed quite clearly that if you match GAD positive slightly older patients with GAD negative slightly older patients who have both had ketoacidosis, the ones who are GAD negative may have a chance of normalization of their glucose levels with oral anti-diabetic agents or even with diet and exercise. And what is dramatic is that the C-peptide levels increase, particularly the postprandial C-peptide levels improve significantly over a period of about a year. So these are basically about 30% of diabetic ketoacidosis from our rather modestly sized series, more common in overweight males, tend to occur once again with a shift to the left in younger people in India when compared to the Western population. So therefore, in the late 20s, occasionally people less than 20 years of age, strong family history of type 2 diabetes, and can be managed with diet or oral anti-diabetic agents. The other specific types I will come to now are the inherited forms, which are also fairly important, and we have recognized them over the last decade and a half as important differential diagnosis. And these are particularly, once again, important to recognize because an important subset of them can respond to oral anti-diabetic agents. So MODY, or maturity onset diabetes of the young, classically is described as a condition which occurs with its onset less than 25 years. Remember, onset and therefore could present later even if they had their onset earlier. Generally, with a 3-generation family history, generally non-insulin requiring and thought to be monogenic and usually with a non-obese state. Now, when we look at there are 14 types of MODY now, and this would need a fair amount of time to talk through it, but I'm not going to talk about them. But from the WHO perspective, the important forms are the ones listed in their classification as more common. And the ones listed over here, including one which is not traditionally MODY, which is a mitochondrial mutation, which I am pointing out over here. All right. And all these forms have actually been reported in our institution, in our molecular lab in the last few years, the ones which I've shaded in gray in particular. And this was published about 6 years back, which looked at the causes of MODY in our population using the state-of-the-art next-generation sequencing. Now, if you look at the Western literature, it talks about MODY 1, 2, and 3. The hepatic nucleotrophic factors 4 alpha and 1 alpha, that is 1 and 3, MODY 1 and 3, and the glucokinase mutation. But what we found in our population was a little different. Now, here is a classical picture, and it shows you how important it is to draw a good pedigree chart, looking at all the cousins, the uncles, and the aunts on the paternal side who have diabetes. GAD antibody negative, fasting glucose high, and this is a patient with glucokinase mutation wherein you can manage, unless they're obese or pregnant, just with diet and exercise and no need for any anti-diabetic agents. Another patient, a 25-year-old who came with a miscarriage at 6 weeks, also had uncontrolled hyperglycemia, was subsequently controlled with a combination of metformin and sulfonylureas, and the mutation showed MODY 5. Imaging shows multicystic kidneys, which is a feature of MODY 5. They can also have uterine anomalies and can have absent VAS in male patients and therefore infertility. In addition, can have proteinuria at an early age. Now, when we looked at our series, we also found some patients who had double mutations or digenic mutations. So therefore, father here has one kind of MODY on metformin. The other mother has another kind of what's MODY 12 on glibentamide, well controlled. But the son has a double mutation and therefore required insulin and not oral anti-diabetic agents. So it's like a dose effect of 2 mutations in the offspring, and therefore you can have digenic MODY mutations as well. Now, MODY, particularly MODY 1, 3, and MODY 12, all respond to sulfonylureas, and it's important to remember this and therefore identify them. And it's particularly the ones with the 2nd generation sulfonylureas which work well. Those with the carboxamidine moiety are the drugs, the medications that work better in these kinds of MODY which respond to sulfonylureas. And even children, small children, 1-year and 2-year-old, when they're given small quantities of sulfonylureas, they don't need insulin and they can be well controlled. We also found a subset of our patients who were young, pregnant women who had pre-gestational, gestational diabetes. We asked the question, why should they ever have gestational diabetes or pre-gestational diabetes? And indeed, those who had more severe disease, who were on insulin, there was a higher proportion and a chance of having MODY over here. And we found a few patients as well. Of course, this is a tertiary care referral bias where we might have also got patients with more severe disease. Summary MODY is seen in about 30% of subjects in next generation sequencing in a population of those who have young onset diabetes. And particularly if you take a very good family history and you have it, the chances are much less, maybe around less than 4% if you don't have a family history. C-peptides are a simple test that can be done because they have lower than normal C-peptides, but not very low like type 1 or fibrocalcific pancreatic diabetes, intermediate level, and their response to a meal is not as good as what one would see in type 2 diabetes or some other forms of diabetes. They can be digenic, and we have a 62 gene panel which can cover most of the inherited forms of diabetes that are labeled till today, including insulin deficient, insulin resistant, and syndromic forms of diabetes. So at one shot, you can do an entire panel. This is another cause, mitochondrial diabetes, 28-year-old with lean diabetes. And then subsequently, the daughter presented with a muscle weakness. And we therefore thought that there is some inherited syndrome over here. And because of muscle weakness as a myopathy, the possibility of a mitochondrial disorder was considered. This child had recurrent episodes of lactic acidosis. And once again, the strength of using next generation sequencing to make a diagnosis of mitochondrial diabetes was here. This is a child's muscle biopsy, which showed evidence of ragged red fibers, which is typical of a mitochondrial myopathy. So mitochondrial disorders can be multi-system, and different members of the family can present totally differently. Deafness is the classical presentation of mitochondrial deafness and inherited diabetes. Though the classical inheritance is maternal and dependent on mitochondrial DNA, you can have nuclear DNA, and therefore patients can inherit it from the father's side as well. So the muscle involvement as myopathy, epilepsy can be another presentation, cardiomyopathy can be. And so when you have these different presentations along with diabetes at a younger age, cardiac involvement, neurological involvement, think of mitochondrial diabetes as a problem. It's not that uncommon. The other monogenic disorders are the insulin resistant forms. And once again, the WHO classification is comprehensive. We have seen these forms, the other two which I have not labeled, are rare forms seen in early childhood with severe mentally challenged state. But these are the forms which are called lipodystrophies. And a classical example over here is a young lady who came with a pseudo-Cushingoid facial appearance. She was 18-year-old, was on premixed insulin, and she used to default from her insulin periodically, but never used to develop ketoacidosis. Her sugars used to jump to 400 or 500, but she wasn't ill when that happened. So she was ketosis resistant, as we'd call it. Triglycerides were high at an early age, and you can see over here that her fasting insulin levels were high, C-peptides were elevated, both in the mother and the daughter had a high triglyceride level in addition, indicating severe insulin resistance, free fatty acids circulating all over the place, perhaps a fatty liver on ultrasound in addition. And the distribution of fat is skewed towards the upper part of the body on the DEXA, and this is a partial lipodystrophy. And once again, this is one of Dr. Asha's cases wherein a genetic testing was done and showed evidence of a laminin mutation, which is typical of a form of partial lipodystrophy. These patients in a subset, once again, respond well to pioglitazone. Some of them respond to pioglitazone very well, and you can cut down the insulin dose or even, in fact, stop it in some cases. And there is no bar to you trying other oral anti-diabetic agents in combination with pioglitazone in such situations. So there are a number of other syndromes which you are familiar with, like Down's syndrome, the obesity syndrome of Rodden's beetle as well, and in which case, let me tell you that we do the genetic screening for these obesity conditions as well, and Prader-Willi and Turner's, which all can come with young onset diabetes. We come finally to the endocrine disorders of the pancreas, and it's really important to remember because this is a tropical disease. This is a very Indian disease. Fibrocalcic pancreatic diabetes classically presents with abdominal pain in the first decade of life. It is very often unrecognized as psychogenic or worms in a child, but it may be low-grade pancreatitis. Maldigestion or steatorrhea in the second decade, and then fibrocalcic pancreatic diabetes by the third decade, and occasionally a little later, maybe sometimes in the early 40s, but usually by the time they are in their 20s. And these patients usually would have low C-peptide levels, and their imaging, a plain X-ray would be the most cost-effective, but you might miss out on a few patients. So an ultrasound would pick up duct dilatation, but the best, of course, would be a CT to pick up duct dilatation and large stones within the pancreatic ducts. Now, these patients, of course, have very low insulin levels when compared to normal people. But the paradox is, in spite of their calcified pancreas, which is grossly destroyed, they do have elevated glucagon levels. And this is a major paradox. And we do believe that this glucagon is being produced by the L cells of the intestine, because the pro-glucagon genome, which is there, which normally produces GLP-1, starts changing its regulation and then produces glucagon at the same time. And now, whether this is responsible for part of the pathogenesis of diabetes itself, we really don't know. This is just showing you that the other L cell hormones are also increased in patients with fibrocalcic pancreatic diabetes. How do you treat these patients? They are insulinopenic, therefore they need insulin. If you find someone who's got a BMI of more than 30 and has a calcified pancreas and has mild diabetes, that's not fibrocalcific pancreatitis. That is a patient who has some calcification in the pancreas and who probably has type 2 at the same time. So they are lean, they need insulin for their anabolic needs. They need adequate dietary replenishment, so they may have high calorie requirements up to 2,500 calories in their diets with adequate protein, and they need enzyme supplements as well to improve the fat absorption in addition. They also have a very high propensity for pancreatic cancer. So by the time they are 40 or 50, if they've lived through their malnourished state and are treated well, we need to screen them every year with an ultrasound of the abdomen and a CA 19.9 to look for pancreatic malignancy. Finally, we come to a condition called unclassified diabetes. The WHO unceremoniously disposed of a particular form of diabetes in the 1990s. It was called protein deficient diabetes mellitus, a subclassification of malnutrition modulated diabetes. And remember, India still has a very large burden of malnourished people, children, the largest in the world even today. And these children could be susceptible to other metabolic problems. This particular disorder, described way back in the 1960s, was a condition which was ketosis resistant. They were extremely lean with BMIs less than 18.5 kg per meter squared, and they usually had a very poor socioeconomic status. They still do. This condition may not be as prevalent in states like Tamil Nadu and Kerala, but is still found in rural areas wherein the socioeconomic status is poor. They do not have pancreatic calculi and they are GAD antibody negative. So these patients actually have insulin levels which are low, but not as low as type 1 diabetes. The blue line you can see over here. They also have an abnormality in pancreatic fat, which appears to be very high. And we don't know whether this is an epiphenomena or whether it is causative. This high fat content is also seen in patients with kwashiorkor, the spillover phenomena. And whether this is responsible for beta cell dysfunction, we really don't know, once again. But basically, these are patients who need insulin and, of course, need an adequate protein diet in addition to the insulin for treating them in addition. And they're found in remote parts of the country, particularly in rural areas. So this is not lean type 2. There is a misnomer by wherein these patients are called lean type. They are not type 2. Type 2 has adequate beta cell function in the initial phase. C-peptide levels are high. These are lean people with low C-peptide levels, and they are grossly malnourished. Now, finally, type 2 diabetes, and this is an emerging problem which is becoming more common in young children. We're seeing a lot of them. Once again, they are amenable to major lifestyle intervention, which makes all the difference. So why these are the conditions which predispose for a young child with type 2 or an adolescent with type 2. Impaired glucose tolerance in childhood, which is actually becoming quite common. Our school studies have shown that 20% of some schools have young males with impaired fasting glycemia. Maternal history of gestational diabetes, a sedentary lifestyle, and a psychological impact. Stress factors. This phenomena called this particular scoring system called an allostasis scoring system should be done in every young person who comes with young onset diabetes who does not have ketones positive. Basically, psychological disability, low morale, or a psychological breakdown on both ends of the spectrum cause a change in stress levels, and this can have an impact indirectly through the hypothalamus and onto the pancreas. So these are the factors which are used in an allostasis score, and it's very important to take this in your history when you have a young person who may not look like a typical type 1. Well, you could take this in everyone. Look at these factors which are now pretty much common in many families. Academic stress is also pretty important, and we talk about failure in a marriage, etc. They're all there in the scoring system, which is quite large. Goes on to one more page, which I'm not showing you. So these type 2, young type 2s should be identified. They have high C-peptide levels. They may be obese or mildly overweight. And lifestyle intervention is critical. Good sleep, regular exercise, a proper diet, and a balanced lifestyle, and not pushing the child too far. So medications, they respond to metformin. Pioglitazone is also effective, and particularly glimepiride, which has been shown in some studies in young children to be effective in controlling sugars. And in the very obese in particular, liraglutide is a good medication to use. Now, the bad news, of course, is that if you have persistence of hypoglycemia without which does not respond well to lifestyle, and you have to continue to use more than 2 oral anti-diabetic agents, they are more at risk for beta cell failure and may need insulin faster than the regular adult type 2 diabetes. They're not exactly the same, therefore. So let me summarize. When you have a young person with diabetes in India, what does it mean? You should think of all these conditions which I've listed over here. And the ones I've highlighted are more common. So type 2 in a young person, and of course, type 1 is very much there. Type 1 is the commonest. Type 2, fibrocalcic pancreatic diabetes, maturity onset diabetes in the young, and ketosis prone diabetes. These are the lists which are common. The others are not rare, but they are just a little less common, and you need to look for them as well. So this is how we can identify, how we use C-peptide levels. It's a useful test. Not all of you may have genetic testing at your fingertips. If you do have a patient, you can always send the samples to us. We're quite happy to do it for you. Having said that, at the preliminary level, you can always look at the simple examination, the history, presence or absence of ketoacidosis, looking at BMI, proper syndromic measurements, and then go down to looking at measuring C-peptide levels in the fasting and the postprandial levels. So over here, you can see that in type 1 and ketosis, fibrocalcic pancreatic diabetes and protein deficient diabetes, the C-peptide levels are low. Maturity onset diabetes, they are low intermediate. In ketosis prone, they are low, but they normalize later on. And in partial lipodystrophy, type 2 diabetes, complete lipodystrophy, you have elevated C-peptide levels. And of course, syndromic disorders, they may be variable depending on what syndrome you're dealing with. So let me pass on a message to you. When we looked for young onset diabetes for an obscure cause, and many patients are referred to us as cause unknown. But when we check GAD antibodies and ultrasounds, this is what we got. A lot of type 1s were actually undiagnosed. We did this as a screening for a particular study. But what we found, interestingly, that a lot of patients in the periphery were not properly phenotyped. The GAD antibody is useful, could be checked where it's available. C-peptide could be checked. And a screening ultrasound of the abdomen should be done in young people with diabetes. So that's it for now. This is your reiterating the important algorithm that you need to do. And I'd like to thank all the staff who have contributed towards this clinical wealth that we have here in CMC and those who have supported us in our research as well. Thank you for your patient listening.